Hi, good afternoon, everyone. Thanks for joining us for teaching, the DDU teaching today. So very kindly, we're going to get one of the ICU specialists at Nepean who's going to be hosting this. And this is Benny Samadi, who's joined us here at Nepean in Sydney, having just finished off a fellowship over in Canada and just got a American Echo Board exam. So congratulations on that. And she's going to be taking us through diastolic dysfunction. So I guess without further ado, I'll hand over to Benny. Let me see if I can pull up your talk. You happy to go straight to that?
Yep.
Cool. Excellent. After you.
Awesome. Okay, so I guess what I'd like to do today is kind of go through conceptually how to think about diastolic dysfunction, some of the theory, and then we'll jump over to the other side and do some cases. The reason why I'm talking about this is because I went to the ASC review course, and I don't know if you've heard the name Dr. J. Ho, but he wrote like this Bible textbook that like the cardiologists actually got him to sign, you know, at the course. And he's involved in making the guidelines, and he gave an excellent lecture there about how to think about diastology and some guideline conflict and stuff like that, which was really interesting. So a lot of what I'm going to be saying is kind of I've learnt from that course and from him. So, okay. So the guidelines, so these came out in 2016, quite different to the previous ones, which means that as I discovered in preparing for this talk, if you look back at old echoes, the diastolic dysfunction grade that they give you might actually be different. And what they actually found when they changed the guidelines was they got more people as normal, they got less diastolic grade 1 diastolic dysfunctions, and they got more indeterminate. So basically less, if you believe the current guidelines, less false positives. So this is the, so it's two flowcharts. One is with people who have normal ejection fraction, which is what you see now. And then the next one is people who have abnormal ejection fraction. And then this also should actually be applied to people who have a normal ejection fraction, but have something else going on. So if they have a hypertrophic cardiomyopathy or a structural defect or something like that. So they would also go into the second algorithm, not the first one.
Can I ask, do you consider hypertrophy to be a structural abnormality? Because I have been including even a mild hypertrophy. You know, you've got to have that for some reason. And if they've got a normal ejection fraction and some hypertrophy, do you consider that a structural abnormality?
So the guidelines say systolic dysfunction, hypertension, okay, coronary artery disease, diabetes mellitus, and left ventricular hypertrophy.
Okay, cool.
But that raises a really good point in that when you go down this algorithm, if you notice, if you go down the left side, there's actually no option to say that they're normal, which is wrong. Like basically you have to give anybody with those problems a grade 1 diastolic dysfunction. But I mean, if you're answering an exam, sure, but in clinical practice, you can use your clinical judgment to say that that's probably normal. Because people with like athlete's heart, for example, they're going to have like huge ventricles, but actually functioning totally normally. So I think you can put your clinical judgment on top of the guidelines. Is hopefully.
That's one question on the first classification. Mm-hmm. So the patient with normal ejection fraction. So that classification is just telling you whether diastolic function is present or absent.
Yes.
You classify grade 1, grade 2, grade 3.
Then you go down this one. So here you just have normal diastolic dysfunction indeterminate, which we'll talk more about. And then if they're more than 50% positive, then they have diastolic dysfunction.
It's saying just a positive or negative. It's not showing it.
Yeah, but if you're positive, then as they say, you then go into the second.
Then go to this one as well. Yeah. So this is for normal ejection fraction and diastolic dysfunction. You go to this one. Or an abnormal systolic function, you just go straight to this one. And then all the other abnormalities that we mentioned, you just go straight to this one, you ignore the first flowchart. Does that make sense so far? Okay, so that's practically how to do it. I think conceptually, the diagnosis of a diastolic dysfunction hinges on LV relaxation. So a lot of people think diastolic dysfunction raised feeling pressures, but actually the first thing that goes wrong is the LV relaxation becomes impaired. It becomes slow and delayed. That's the first step, and that's before your feeling pressures go up. So the next step would be raised left atrial pressures. So for example, and you can see that in this flowchart actually, because a grade 1 diastolic dysfunction is actually saying your LV relaxation is impaired, but your left atrial pressure is normal. And then as you go to grade 2 and 3, then you have raised left atrial pressures, or raised feeling pressures, if that's what, raised feeling pressure is a pretty vague term, but yeah, if that's what it means to you. Other things that you get, so this is just sort of, we've seen this about 1 million times since med school, and you can kind of see that as your LV relaxation, it becomes impaired, really that pressure curve kind of shifts. It becomes a slow deceleration. So this is probably the most useful picture in terms of how to think about what's happening in various aspects of the heart as diastolic dysfunction progresses or becomes worse. So we have the normal on the left, and then the first one is the the second column is the impaired relaxation. So that's your grade 1. Then you get pseudo-normal, which is your grade 2. Then you have this restrictive pattern, which is your grade 3. The other things that I just want to point out on this picture, which is pretty helpful, is your interventricular relaxation time when you have a mild or grade 1 diastolic dysfunction gets prolonged. So it becomes more than 100 milliseconds. And that's, and if you're stuck and you need some other extra measures to decide if somebody has or doesn't have diastolic dysfunction, these are extra things that you can look at. So your interventricular relaxation time is only prolonged in a grade 1 diastolic dysfunction. Then when it gets to pseudo-normal, it also pseudo-normalizes. And then when you get to a grade 3, it's quite short.
Do you recommend measuring those? Because I know you've got a couple of ways of doing it. You can either do it on a TDI, or you can do it by that special bit where you put the pulse wave Doppler in between the LVOT, so the outflow, and the mitral valve, so you can kind of pick up both inflow and outflow. Which one do you recommend?
I think the pulse wave on the TDIs, I think it gives you, if you have this nice little bounce, it gives you probably your best bet for your intervention. Yeah, so your tissue Doppler, on your tissue Doppler, I think that for me, I think that's the easiest for me to identify that time period. Otherwise, I don't know what I'm looking at. Then when you get to, okay, so then you have a pseudo-normal, and unfortunately everything pseudo-normalizes. So if you see on the second line, can they see the mouse on this? Yeah. So on this second line.
Am I right in saying that, guys? You can see the mouse?
Yeah.
Okay, so on this second line, as you pseudo-normalize, unfortunately, pretty much everything pseudo-normalizes. So your interventricular relaxation time normalizes, your deceleration time normalizes, your EA ratio pseudo-normalizes. So that stuff's not particularly helpful. And then we'll talk about other ways to differentiate pseudo-normal from normal. And then when you get to your grade 3, everything gets very, very short. So your deceleration time, your interventricular relaxation time gets very, very short. Now, the thing that I like about this picture is, so you can see that your E wave velocities go down and then they go up again. And then on your pulmonary vein Doppler, your D wave mimics what the E wave does. So I think in terms of absolute velocities, your pulmonary vein Doppler is not that helpful because you can kind of guess what it's going to be based on your EA velocities. So that goes down and then it goes up again. What is helpful from the pulmonary vein Doppler is your atrial reversal wave, which is this one here. And I'll get back to that. That's very helpful. If you can get a good atrial reversal wave, that helps differentiate diastolic dysfunction. Now, the kicker is, and this is what's going to help you when you have a pseudonormal pattern, is your E prime, so your tissue Doppler, because that just goes down. So that's why that E over E prime ratio is so important, is because you're only, that this E prime is, the diastolic dysfunction definition and diagnosis hinges on that, basically. The other thing about the tissue Doppler, so the E prime, is that it's less preload dependent. They say preload independent, but I don't think anything's really preload independent. So with you have your E velocities, like in your mitral outflow. So this one, that's actually quite preload dependent. That's why you can't use an absolute velocity cutoff. It's always going to be different depending on the loading conditions of the heart. But your E prime in the guidelines. So if we go back to the guidelines, you see that there's clear cutoffs for the velocities of the E prime because that is actually more preload independent. Does that make sense? I'm getting a lot of blank stares.
No, I agree. Do you think, because I think that's one of the best things in the critically ill, the E prime, you know, there's a lot of discussion about the E on E prime and it's not validated in the critically ill and whether we should use 14 or we use 18 as a cutoff, but the E prime is the one that's was being shown in animal models in the critically ill in septic cardiomyopathies as probably being the best mimic with, the best mimic with tau, I think, on invasive measurements. So you said the E to E prime. Do you mean, should we just be looking at the E prime in your opinion, or should it be the E to E prime as well?
Yeah, you can just look at the E prime, but there's a couple of caveats with that, which is why you find that basically the crux of the talk is you can't use any one measure. Yeah. So the couple of confounders with the E prime is mitral annular calcification, prosthetic mitral valves, and then anything where you have abnormal septal motion, because that's going to mess up your annulus excursion. So left bundle branch block, when you have high RV pressures, pacemakers, that sort of thing. So bundle branch block, yeah. So I think you can't really just use the E prime, but if in the absence of those, yes. And the other interesting thing that I heard at this lecture was actually in the guidelines as well. Your E prime is normal for it to go down with age. So when you're over 60, a lot of those people are actually going to qualify for at least a mild diastolic dysfunction because it's normal for your E prime to go down. So then they're going to kind of falsely be diagnosed with diastolic dysfunction when actually it's normal. It's normal for the LV to stiffen up a little bit with age. So that's the other thing. And it's not validated in children, of course, but so there's a couple of caveats. But yes, I think if you were just going to look at one measure, I would go straight for the E prime. And then build my diastolic dysfunction diagnosis off of that. And then the interesting thing is that E prime of greater than 14 is the cutoff for your average E prime. Or if you only have one or the other, if you only have a medial, you can use greater than 15. If you only have a lateral, you can use greater than 13, because that's sometimes a problem. You can't get both. That actually corresponds to a left atrial pressure of 15, or greater than 15 as well. So it's not a linear relationship by any means, but that particular cutoff point happens to be easy to remember. And then when you have the other thing I want to talk about, when you get to, and then the other interesting thing that, Jay.
Did you say?
Yeah.
Sorry, did you say that corresponds to a wedge of?
Yeah, left, yeah, 15, yeah.
So what were the values again?
So if you have E to E prime ratio of greater than 14,
yeah.
So greater than or equal to 15, then your left atrial pressure is greater than 15.
Okay.
And that's in cardiology patients. That's not critically ill.
That's cardiology patients. So that's when they can invasively measure the left atrial pressures, and they found that correlates in their studies. Yeah, make sense?
Mm.
Yep.
Okay. Okay, so with there's not a linear relationship. So it's not like if your E over E prime is 20, then that's a left atrial pressure of greater than 20. It's not a linear relationship. It's just that cutoff happens to be pretty good at saying abnormal and normal. Does that make sense? Okay, so I think part of the issue with the new guidelines is that they got a lot more people being classified as indeterminate. And when I was listening to the lecture, he was like, that we didn't intend for it to stop there. So people kind of just go, oh, well, I can't figure out whether it's diastolic dysfunction or not. So they just put them as indeterminate. But actually what the intention was to do other things that are not on this flow chart to figure out whether they have diastolic dysfunction or not. So some of the other things that we kind of already touched on was your interventricular relaxation time. You might be helpful. The other thing you can do while you're echoing them is a Valsalva. So the Valsalva maneuver is actually pretty good. What happens is your EA wave, both the E wave and the A wave will go down together as they Valsalva in somebody who's normal. So everybody here, when we Valsalva, our EA ratio should, the ratio should stay the same and the absolute velocities just go down. And you should see that with your mitral pulse wave at the tips. Does that make sense so far? And now if they have diastolic dysfunction, it goes the opposite way. So the E wave goes down and the A wave goes up. And a decrease in that ratio of more than 50% is actually very specific for diastolic dysfunction. Does that make sense?
Tell us why that happens.
I think it has something to do with the preload conditions. So, yeah, so I think if you were Valsalvaing, then you'd have to be decreasing the preload, so your E wave goes down, and then that would make your diastolic dysfunction look worse, and then the A wave goes up.
Which phase of Valsalva? Because early Valsalva, you increase your LV preload.
I think you need, so the standardization is the 10 seconds. They need Valsalva for 10 seconds, and then.
So that gets rid of the increased preload bit, and so you're just in the low preload bit. And I think it's all to do with the E wave is active relaxation. It's still an active process that filling of the LV. And so I think it's all to do with your left atrial pressure. So you've got early diastolic dysfunction, you've got normal left atrial pressure. Then if you reduce your preload, the E wave goes down because you've got less preload in a normal left atrial pressure, right? I think as you're starting to get further down the track with the Valsalva, you've still got raised left atrial pressure, and that's what makes it go up. Yeah. So if you've got severe diastolic dysfunction, you do the Valsalva maneuver, what happens to the EA ratio?
It should go.
That still goes down
Yeah.
and goes up because it's all about the preload. So you've still got the, okay, thank you.
Okay. Does that make sense to everybody? I think I'm all confused now.
No, diastolic dysfunction is the hardest thing to talk. That's why I gave it to you.
Okay, so other things that we can do when people fall into the indeterminate category is you can send them for, or you do strain during your echo. So strain should predate diastolic dysfunction. So it goes strain abnormality, diastolic dysfunction, systolic dysfunction, technically. You can do a diastolic exercise stress test, and they kind of describe, but basically you only do 3 parameters during an exercise stress test, which is your annular tissue Doppler velocities, your mitral pulse wave velocities, and your TR jet velocity. So it's just those 3 things, and you can do it as you would normally after exercise stress test and kind of do that in the first couple of minutes. You can look at your pulmonary vein Doppler as well. So the atrial reversal wave. So
Can I ask one
yeah.
question about that? Because in the LA volume index, if you don't have height and weight of the patient, is there any other
Yes.
LA size
It's
we
really
can?
annoying. Super annoying when you
Yeah.
don't have a body surface area.
Is there any LA cutoff size, like in the diameter or something?
I use you can use the area. I mean, it's validated for the meter squared. So I don't think there's an absolute cutoff that you can grab.
Yeah, in the guidelines, the only thing I've seen is the to body surface
Yeah.
area, unfortunately.
I
But
think this is also one of the problems with the guidelines, you know, because to actually get an accurate LAVI, you've got to do your biplane measurement of the left atrium as well. So that means you've got to have a decent 2-chamber, and it's got to be perpendicular to your 4-chamber. And how often does that happen in a critically ill patient? So I personally find it really difficult.
yeah, so what I do is omit that one and then use the other features.
It's interesting. So I think eyeballing it is I don't think I haven't got any validation things to this, but eyeballing in there should be about 1/4 to 1/3 of the size. If it starts looking the same size as the LV or greater than the LV, that's when you're getting in that moderate to severe category for the left atrial enlargement. The other thing in the critically ill is the left atrial, you can get acute diastolic dysfunction like receptive cardiomyopathies. And we got a little bit of data to suggest that it takes at least 48 hours for the left atrium to enlarge.
Yeah.
So, yeah, I agree. I think that's what's nice. I like about these guidelines. So you're not absolutely reliant on the left atrial volume if you can't get it.
If you can't get it, I mean, this with the second algorithm at least, it allows for omitted results, and then you can use some of the other things that we're talking about. What do you think about the parasternal long axis comparing the aorta and left atrium?
I mean, I think it's like doing it for the left atrial side, also doing it for like the Tycholt's method for ejection fraction. It's you've got a spherical structure that's probably not a perfect sphere for the left atrium, and you're measuring 2 points and saying it's enlarged. I think it's okay if that's all you've got. I think you should try and use all modalities you can. You know, see the heart from all sides.
Probably not super accurate.
It's not perfect.
And then, and then on your pulmonary vein Doppler, so this wave here, which is your atrial reversal wave, and then if you look at so you take the duration of that wave, and then you take the duration of the A wave on your EA Doppler, then if that's more than, subtract them, if that's more than 30 seconds, then that's actually quite specific for diastolic dysfunction as well. And I think if you can get a good pulmonary vein Doppler, it's pretty easy to do. It's just the times.
Which one is longer if you got
Your atrial reversal wave.
The pulmonary vein, the AR jet is longer.
This one. So you take this one and minus this one. Make sense? And then, greater than or equal to 30 seconds.
Maybe just a quick tip and trick for the pulmonary vein velocity. The way I find it quite challenging to sometimes try and get it without getting aliasing. So I narrow the sector width right down in my apical 4-chamber view. I put the color box over the back of the left atrium. I decrease the scale on the color box because I'm looking for low flow states. And then I look where you've got something red coming into the left atrium. And then I'll grab my pulse wave box and I'll put it about 1 centimeter distal to the back of the left atrium. And I put it where the color is. I'm not looking for a gap in the 2D picture. I'm looking for where the color is in that color box. And then I sometimes increase up that box gate to about 8, whatever the scale is. It's normally, I think, at 5, and I increase it up to 8, and I stick it in there, and then you press go on the pulse wave Doppler. The next thing that's really important is to then pause the 2D picture at the top. You've got to pause that, because then that means that all the power of that image that you're seeing is focused just on that tiny little point where the box is. And because it's quite a long way away in the apical 4-chamber view, you need all the help you can get. and what I might do is I might see if we can get a little video of one of our sonographers doing it, because they taught me how to do this, and the sonographers are generally the best at doing it, and physicians are terrible. So anyway, that's how they've taught me to do it. I think, Lewis McLean, when you were here, did Iris or Louise help you out with some of that?
Yeah, Louise did. She showed me how to do it perfectly, which I failed to replicate many times.
Yeah, me too. Me too. It's really nice when the sonographers do it. Absolutely right. Yeah. Cool. Sorry to interrupt.
No, that's great. Okay, so I think another thing you can use is the L wave. I think I've mentioned L waves to Sam about 50 times. So you think I'm obsessed with the L wave. The L wave is a little wave, an extra wave off your E descent. So you get a little like bump. Sometimes there's a whole new wave between the E and the A. And the L wave happens in bradycardia, but it's rare. Rarely happens, but it can occur in bradycardia with people with normal diastolic function. But it should be quite low velocity, so it should be like less than 20 centimeters per second. But if you see an L wave and they're not bradycardic and it's more than 40, so the cutoff is 40 centimeters per second, that's quite specific for diastolic dysfunction as well. And then the other thing is the B bump on the mitral tip M mode on the parasternal long axis. That is quite specific for diastolic dysfunction as well. And
the L wave duration, where do you, if it's kind of fused, if it's kind of fused a little bit, where do you start measuring the L wave from the E?
I see what you mean.
It's the end.
You would measure
Is it just kind of
that bump.
valley?
Do you mean when the EA is fused, or when you have the L wave?
If the L's, if the L's kind of attached to the E wave.
What a great question.
I've got a couple of examples.
So the E wave gets kind of skinnier, and so the L wave, takes its own separate form. But
so this one's quite distinct. So you measure the peak of that wave in between, and then this one is probably more like what you're talking about, right? So you have more of a fused kind of view. I look at like this.
I think it's the end of that bit. Yeah, I agree.
Does that make sense?
Yeah.
Yeah. Because I think, you're right. It's like a fused wave, and kind of make out where the fusion is. So that's where I would measure it. So these guys are about 0.5, like so 50, and then this one is probably just above 40. So that's your L wave. What else have I got here? And you can almost kind of see it on your on the inflows there as well. I don't remember why I put this one in.
No.
And that's your B bump. That's quite a prominent B bump. So it's this one.
Check the B bump. So sorry. Do you reckon the B bump's that one?
No, the B bump is at the end.
Ah, excuse me.
So the L wave happens between the E and the A, and the B bump happens after the A.
Excuse me.
Does that make sense? This is quite not normally this prolonged, but this is what it looks like. So there's a few theories about how these waves actually happen. This is another sort of L wave. So I would measure that probably about there. And this brings me to the next point, which is AF. So when you have AF, all your A measurements go out the window, like your EAs and your AR minus A and all those sorts of calculations you can do. So there's a couple of things you can use to say that there is or isn't diastolic dysfunction with people with AF, and one of them is L wave, as you can see there. And then the other thing, which is not totally reliable, but it's a nice little physiological clue. So this person has AF, and the velocities of the E wave are quite consistent. And what you would expect in most people who have AF is every ejection is a little bit different. So every E wave should be a different velocity, and they're always kind of all over the place. Kind of like your LVOT VTIs are always all over the place. But if they're very consistent and they're very uniform, that gives you an indication that the left atrial pressure is raised, and that means diastolic dysfunction. So that's kind of a clue to, okay, this person has raised left atrial pressures.
That's cool.
Yeah.
What about the absolute value of the E velocity? Does that help you?
No, unfortunately. The problem with using absolute values of E velocity is that the E wave is very preload dependent. So every time the loading conditions change, that's why there's no absolute cutoffs in the guidelines, except for when you take the EA ratio into consideration, which is unlike the E prime wave, where it's much less preload dependent. So there are cutoffs like 14, 7, 10. So there are velocity cutoffs for that, but for the E wave, not really. You can still use the TR velocity jet when you have AF, and you use an E over E prime ratio of greater than or equal to 11 rather than 14 as it being abnormal. And you can also use the interventricular relaxation time of less than or equal to 65 seconds and a deceleration time less than 160 if they have a systolic dysfunction, or 130 if they have normal systolic function. Yeah, and you can still use the E prime, the absolute value of the E prime. So that will be low in somebody with AF and diastolic dysfunction. Okay.
And so in terms of grading, you either say they've got, I often say significant diastolic dysfunction with atrial fibrillation, if they've got some of those. This is a bit hard to say the severe, moderate, or mild, right?
It is really, I think it's really hard. I think all you can do really is follow the algorithm. If that leads you one way or another, if you've got enough parameters. But otherwise, these things just kind of tell you if it's normal or abnormal. And but the L wave actually means at least a grade 2 diastolic dysfunction, because you have to have raised left atrial filling pressures for that L wave to appear. So it has to be at least a grade 2. So the reason why the L wave happens, it's a little bit similar to like the flying W with pulmonary hypertension, is that you have when the gradient between the left atrium and the left ventricle at the end of that E wave, it should be 0, but it's not. It means you've got ongoing forward flow from the left atrium. That creates another wave. That's your L wave. Does that make sense? So that's how the physiology links in with the waves that you're seeing. Okay, should we do some examples?
Let's do it. Should we jump over? I'll flick this over. Okay, can everyone hear us?
Yep.
Okay, so let's presume for this patient that the systolic function is normal. It does look pretty normal based on that. But so let's just walk through the algorithm just so we can get a feel of how it works. Okay, so what do we want to look at? What's the first parameter you would look at?
Like atrial size looks big.
Left atrial size. Okay, so
On this, it's a story on left atrial looks big.
yeah. Okay, so this person, I can't remember actually if they had a. Yeah, so this was an index to body surface area, so which is pretty common.
It will be on the actual report
It will be.
itself. Can you see if I've got
Oh,
it?
it's just there. Okay, what else? What else do we want to look at? What?
So,
Yep.
So we looked at the so in the 2D, looking at the left atrial size, looking into atrial septum, looking at the morphology of the LV, see if it's got increased LV mass or not.
Yeah. So if it qualifies for that first algorithm or straight to the second one, second flow.
Mildly common.
So so let's presume that we're just going to be looking at the first flow sheet. There's no structural abnormality, there's no LVH, nothing else, and the left atrium is mildly dilated. Okay, what else do we want to look at?
Is there any TR and what's the T-septal atrial velocity?
Okay, cool. So TR is more than 2.8, so that's a tick. And then let's look at your tissue Doppler.
Medial is less than 7.
It's quite low. And laterally also low. Okay. So this person has, based on off the first algorithm, where would they go? The diastolic dysfunction, right? So let's grade it. So what would the grading be? So let's look at, what do we need to look at?
Yeah.
Yeah. Yeah. So you're going to look at the EA.
There's an A wave. I knew there's a good
Very good.
Nice.
Yep. So, and we've got an EA ratio 1.43.
Middle category.
So middle category. And your E wave, your actual velocity is also qualifies there. Okay, fantastic. Then, so we already know that the TR velocity is high and that the LA volume is high. And the average E over E prime, I think, with the tissue Dopplers being as low as they were, that's going to be greater than 14 for sure. So, which grade of diastolic dysfunction do they have?
I need E and E prime before I can say.
Yeah. So we.
But if it's already more than 15, then I can directly go to.
So it's.
So it's still on there.
Yeah. So it's So you're like.
The ratio.
The ratio, yeah. So your E velocity is over a meter, and then your sorry, I just sort of skipped over that because it's almost definitely going to be it's going to be quite high.
20.
So,
Yeah.
Yeah.
So
Greater than 20.
it's grade 3.
Yeah. It's grade 2.
Grade 2, assuming that your LABI is greater than 30.
Yes.
Yeah.
Yeah. Okay. So even if you didn't have, let's say if you didn't have your left atrial volume, based on the E over E prime and your TR velocity, you would go down to a cannot determine, and you can use some of the other things. But the worst, if you're in that middle category, the worst grade of diastolic dysfunction you can have is grade 2.
That was E ratio, what we do, that's the grade.
Yes. Yeah. Okay. Okay. So this person actually has a this is just to show you that you can't use one measure. This person actually has a deceleration time of more than 100, and that should actually put them in. If we only use that, then that would actually put them in a grade 1 diastolic dysfunction, but that's clearly not the case. Like we've got several measures that are pointing to a grade 2. So they say if you have 2 or more measures that are consistent with the one category of diastolic dysfunction, go with that one. That makes sense? Okay.
Then can you show us on these images where you would measure the isovolumetric relaxation time?
Is it the L wave?
Is that possible?
Yeah, so this is the L wave, yeah. This is the L wave.
Would you show us how to do that on the tissue Doppler, please, Vinny?
Okay, so Sam can look over my shoulder and make sure I'm doing this correctly. Go to time. So I would go measuring the interventional relaxation.
So it is tough on this. So the first thing I'd do is make sure that you optimize your image. So we're looking at trying to measure a tiny little section. So doing it on a sweep speed, which is markedly reduced, is really important. So here you can try and find it's where the systolic wave comes back to the baseline from when the next E wave then comes down. Yeah. So for example, can I borrow the mouse for 2 seconds? So I'd be measuring it on here in time, for example, from like there to there.
Got it.
Yeah. So it's from where that systolic waves come back down to boom. So right from about there to when the E wave comes back down. And what you can see here is it's a bit fuzzy, right? You know, we can kind of move the numbers around, and it varies. And that's why it's actually much better to do it. And so I completely agree with Benny when she says it's much better to do it with that pulse wave box. That if you put it just in the area where you're in between the LVOT and the mitral inflow, you can get both. It's on a Doppler, it's much easier.
Yeah, because the difference that you're going to measure in the middle of the line or at the start of the line or at the end of the line, and how thick the line is, isn't it? So, yeah.
So you've got to have an optimized tissue Doppler trace.
So I think if you can get a few as well, because when I try this, and then if I have one and it's like 60, and then I have another one that's like 90, I just don't bother because it's like I can't figure out what's going on. But if I can measure a few and then they're quite consistent, then I'll use it.
Sure.
Can I suggest the other reason when I start doing measurements like this is only if it sort of feels clinically relevant. You know, I think if you've got someone who you're investigating for a systolic murmur with an ordinary ejector with a normal exercise tolerance, or in a critically ill, if there's obviously clearly no horrible problems with pulmonary edema or something like that, I often don't worry about doing this, and I'll probably just leave them at indeterminate and not stress too much. But it's only when it becomes clinically relevant, that's when we need to start doing these. So it's not for everyone. And you've got to, being a physician first and then being an echo person afterwards, I think is important.
I totally agree.
So what was the cutoff for IVR?
So if really the only cutoff is for a grade 1, if it's more than 100 milliseconds. Yeah. And then everything else sort of pseudo-normalize, and then I get really short lines with diastolic dysfunction. And then this person doesn't have a great, not the best pulmonary vein Doppler, but that just shows you could. That's probably not where I would measure it, actually.
I totally agree. Yeah.
But you could measure the atrial reversal wave, and then get your atrial wave duration, your A wave duration, and then do the AR minus A. Yes, so I completely agree with Sam, not clinically relevant, or you could develop, an obsessive compulsive disorder like me and fixate on.
But this one totally was relevant. So the presenting complaint for this patient was someone who is CCF with fluid overloaded on a chest X-ray. Yeah, so I think it is important to start talking about diastolic dysfunction when someone looks like they've got a normal systolic function. Yeah, that's important.
Yeah, that's because it's really what they're hunting for, right?
Yeah.
Okay, so let's try. Any questions, comments, feedback, anything else so far? We can try. Let's do another one. How much time have we got? Maybe we just do one more. Okay, so with this guy, okay, it's not that bad, but let's presume that there's some systolic dysfunction there or some LVH or whatever. So let's just go straight to the second algorithm. So what do we want to look at?
So EA ratio.
So EA ratio, very good.
What's that? EA more than 50 centimeters.
I can find it.
You can increase the gain if you want to.
Oh, yeah, thanks.
Right, next one. Sorry,
Oh,
the next
sorry.
gain. That's sorry, the gain. That'll be it.
Okay, so what's the problem here?
Patients in AF, or there's no, doesn't look like
Or
that.
it's, I think it's paced as well.
Yeah,
Or both, probably.
yeah.
I think, yeah, he's in atrial fibrillation. Yeah.
Fibrillation.
And
Can I just ask a slightly related but different question? When do you tend to get fusion of the E and the A waves on the mitral inflow?
when they're really tachycardic,
Yeah.
then they'll squish together, and that makes it really hard.
Okay, so there's nothing in particular that you can do apart from.
Not really.
Okay,
Not
fine.
really. Try again when the heart rate's lower. I was reading the guidelines. They say that if the fusion is, if that point where they fuse, where the E and the A fuse, if that's 20 centimeters or less, then your measurements are still going to be pretty accurate.
Okay.
Um,
Yeah, because sometimes they're sort of squished together and you're like, oh, I think it's here.
Yeah. So if they're like super squished, don't bother. If they're a little bit squished,
I guess you could still use like your E on E prime and stuff and just
Yeah.
about the A wave related parameters.
Yeah. Like you wouldn't be able to do like an A wave duration.
Yeah. Yeah.
But like, hey, after this, I've got like 20 things you can measure. So there's no excuse.
Got a whole list of them here. L waves, TR, jet velocity.
So yeah, okay. So this patient's in AF. So we can't really use the EA, but we can use something else.
All the 3-4 things, the TR jet and your E septum,
Yeah.
E medial,
Yeah.
your
Yeah.
P and E prime.
So it's E prime, I think you said E, you mean E prime medial and E prime lateral.
Yeah,
Yeah.
medial and lateral, 7 and 10.
It's gonna
So what do we think of that lateral E prime?
pretty low.
Oh yeah.
Can I just jump in at this stage? Tell me what else you think about this image. I think this is reasonable to say if you're in the exam. And he's gone back. I didn't take it. Back it up.
The gate width seems quite wide.
No, okay, that's a fair enough point. Yeah, you got a wide gate width there, and I don't think you need it. It should be close to, say, 3 to 5. Yeah, fair enough.
The scale is also.
Yeah, I mean, look at this. So we're interested in measuring things at like 0.8. One of the things that really gets to me is inadequately optimized Doppler images. When we're starting to measure, if we're worried that 0.8 is the cutoff here, I would argue that we've got to be looking for the modal velocity when we're looking at these images. And that means that you decrease the gain and you measure where it's at its brightest. So if I was measuring it, I'd be measuring it about there. So I've got it at 9, and you take the average of 3 of them. So we've got 9, 8, and 10. So it's probably 9. Maybe I'm being a bit pedantic, right? But if you've got the gain up super high, and I'm obviously exaggerating a little bit there, if you start measuring it where you think the modal velocity is there, you could be going at, 11, and 12. So it's really important that, first of all, you get your scale right. You've got what you're interested in filling the screen, and then you turn down your gain. Oh, I can just get rid of all of that. Turn down your gain and go from there. I've really messed up that picture, haven't I? Hang on a sec. How do we get there? Let me just go forward and back. So if you're measuring this, optimize your scale, 3 to 4 cardiac cycles filling the screen, measure 3 samples, and turn down your gain. Okay?
And if AF, you'll do 5.
AF, you do average 5, absolutely. I'm sorry, he's an AF, so he should have said 5.
Okay, so you can still use the TR velocity. That's still pretty good in AF to point towards high left atrial filling pressures in the absence of pulmonary disease. So if normal lungs, no reason to have pulmonary hypertension, then this is a pretty good indicator of left atrial filling pressures. And then, yeah, and then it's pretty consistent as well. So there's not a lot of, there's not a lot of variability. It's really faint, right? So pretty consistent from beat to beat in terms of the absolute E velocity. And then the other thing we can do is deceleration time.
Would you say there are L waves there as well?
Yeah, maybe. Maybe.
Nice.
It's, I don't know if I've got one clear enough to measure it, but there's probably the hint of an L wave there. It's not the best inflow Doppler, sorry. And then we can do, how do we do deceleration time here?
You get E set, maybe do, yeah, E time, yeah.
Yeah, ratio.
Otherwise, it's in micro.
Yeah, good call. Yeah, click on that, and then just follow it down, and then trace it down.
Oh, okay.
And yeah, press that. There you go. Oh, we've messed you up there.
Yeah.
Sorry, you got to do it in your mitral valve.
Oh,
it's configured differently in the. There you go.
Okay, so if we take.
I'm really sorry, it's configured differently on this system.
162. Okay, so you've got a deceleration of 162. So this guy has at least a grade 1. Make sense?
Nice.
We can go through another case, but I think that's kind of time, right? Yeah.
Benny, thank you so much for going through. That's a really challenging topic, and I think you went through it great. Are there any questions for Benny about any of this?
No, thank you, Benny. I feel like I have slightly progressed in my long, slow journey towards understanding diastolic dysfunction.
And I tell you, I feel you. It is really hard, isn't it?
It's very much 2 steps forward, 1 step back.
Yeah.
Every time I think I understand something, I get confused again and have to relearn it.
Well, that's great. Well, thanks very much, guys. I'll see you next week.
Thanks very much. That was awesome.
Thank you.